All right, so thank you for allowing me to present my work and funding me. Yes, okay. So thanks for allowing me to present my work. Yeah. Is it on now? Oh, yeah. Okay. All right, we're working. Great. So I'm just going to get started then, so we don't waste time. Great. No disclosures. So very briefly, just to give you guys all a primer. So urgency incontinence is leakage of urine associated with a sudden desire to void. And it's pretty common. So 30% of women over the age of 30 have this, and the prevalence significantly increases with age. And the lovely Dr. Nagar just told me that it decreases work productivity by 40%. So also a ding for women. So treatment typically starts with behavioral modifications, pelvic floor physical therapy, and then we move on to medications. And then our third line therapy involves onabotulinum toxin A or Botox, sacral neuromodulation, and percutaneous tibial nerve stimulation. And for this talk, I'll just be focusing on Botox and sacral neuromodulation. And very briefly, Botox is a cystoscopic injection. So we put a camera inside the bladder and then inject Botox, which paralyzes the bladder muscle. And then sacral neuromodulation is a little bit different, where we actually implant a lead into the sacral foramen, and that modulates the afferent or the sensory signals of the bladder. So very different. But the big question is, how do we pick, right? We kind of know what the outcomes are for these therapies, but as clinicians, how do we decide? Or as patients, how do they decide which therapy to use? And we have done some, or I have done, and myself and others have done some predictive modeling. But unfortunately, I think the outcomes that we have thus far are inadequate in terms of predicting how well women do. So what do we know so far? So far we have a nice ROSETTA trial. It's a multi-center randomized control trial that looked at women with refractory urgency incontinence, and they were randomized to these two therapies, Botox and sacral neuromodulation. And the primary outcome for the ROSETTA trial was a continuous variable, and that was change in daily urgency incontinence episodes over 6 months. And as most trials that analyze a continuous variable over time, they used a linear mix model. So we're going to get a little stats heavy here. But a linear mix model basically averages data at every time point that it's collected over time. So you, in essence, get one value. And so the result for the ROSETTA trial showed that there was about a 60 to 70% reduction in leakage episodes for both therapies over the 6 months. And if you were to graph this kind of improvement over time, you can see here that pretty much both therapies had a pretty significant improvement initially, and then at least for Botox, that therapy kind of waned, or improvement waned over time. But that's not, however, in response. So this is just a single patient in red here, taken from the ROSETTA trial. And as you can see here, her response is not as good as the population average, shown in blue. And this is just another randomly selected patient from the ROSETTA trial. And again, her response is completely different from the other patient, as well as the population average in blue. So really giving all of these women just one number in order to describe their treatment outcomes is probably not the most accurate prediction. So, and in fact, if we define failure as less than 50% reduction in leakage episodes over 6 months, we find that 36% of people actually do that fluctuation between success and failure after Botox, and 43% after sacral neuromodulation. So a pretty significant number of people are fluctuating. So the primary objective of this part that I'm presenting today is to describe those fluctuations in women who receive Botox or sacral neuromodulation using a continuous time Markov model. So we chose to use a Markov model because it's been used in other fields whose disease processes kind of do the same thing, where symptoms fluctuate, such as depression, epilepsy, and ulcerative colitis or inflammatory bowel disease. But it hasn't been used in urgency incontinence treatment or in urgency incontinence treatment outcomes before. So for the outcomes for our Markov model, we first looked at objective treatment failure, and then we also looked at subjective treatment failure, so how women actually felt they responded. And we assumed that women began in treatment success directly after their therapy. We used the same data that I was just presenting. So we used data from the ROSETTA trial. There were 353 women, very similar to other trials in urgency incontinence. Notably, they had about 5 leakage episodes a day, and over 50% had pretty severe urgency incontinence. So it was a little bit of a severe patient population. Okay, so to our results, the first thing that we found using a Markov model was that we were able to describe how long patients were in each state, so in success and failure. And what we found was that there was really no difference in the duration of success between the two therapies, but that women lasted or were in success for at least 200 days. And thankfully, women were in failure for a much shorter duration, about 50 days. And again, that was not significantly different between the two groups. Really quickly, because I don't have a ton of time, but subjective failure showed a similar trend compared to objective failure, except the time in success was shorter and the time in failure was a lot longer. So basically, women just didn't feel like their symptoms were improved as much as the diary or objective data showed. So the next thing that we were able to get from a Markov model was looking at the transition rates between states, which basically tells us how fast a woman would transition between states, between success and failure. And when we looked at objective treatment success or treatment response, we found that there was no significant difference, despite kind of looking at the hazard ratio there. It looked like there was about a 26% slower transition with Botox, but that was not significant. And then there was also no significant difference in the transition rate between failure to success for objective treatment outcomes. However, for subjective treatment outcomes, Botox actually did have a significantly slower transition rate from success to failure. So basically, those who received Botox had a longer time in success, and they just went into failure at a slower rate. And there was also no significant difference in the transition between failure and success. So our last outcome that we looked at with this Markov model was the probability of transitioning. So we know how long people are going to be in each state, and we know the speed at which they transition, but what's the probability that they're going to transition into failure or from failure back to success? So when we looked at our objective outcome, we found that there was a lower probability of success to failure transition in Botox and sacral neuromodulation. And generally that probability was around 10%. So not a large number of people went to a failure category. When we looked at the reverse, so those who had kind of had a relapse in symptoms and then went back to success, so had improvement in their symptoms, there was a similar probability of making that transition from failure to success between those groups. And that was actually close to 40%, which is a large minority of patients actually having an improvement in their symptoms after having a relapse. So it's much higher than we, I think, clinically thought in our practice. And since an improvement in symptoms could occur because you've received other therapy, we censored those who received other treatment, and there was really no significant difference. And I don't know how much. Oh, I'm cool. I'm over yet. All right. So I will quickly speed through. There was really no difference. Objective treatment outcomes showed something very similar. And so my conclusion is basically a Markov model adds different and additional information over our traditional models. Right. So our traditional model really just gave us this one number, whereas our Markov model is able to tell us that a large number of patients actually fluctuate between. And I think the other significant results are that those who received Botox actually subjectively failed slower than sacral neuromodulation, and those receiving Botox were less likely to transition to failure. So in my mind, this kind of makes Botox look a little bit better than perhaps we had previously thought. And then finally, the probability of transitioning from failure to success is nearly 40%. So again, a significant number of people may actually have an improvement of their symptoms without receiving any other therapy. And I will skip that. So thank you to all these other people in the room listening and my collaborators.